Hello, thank you for joining me today. My name is Wendy Jones and I'm a pharmacist as well as a breastfeeding supporter. I began working on training for professionals back in the early 2000s with the help of a wonderful person called Roberta Ralston at Peterborough Hospital. And it was her support in developing this kind of trainage package that gave me the courage to go on and record many other webinars, to write my books and develop my website. So I'm eternally grateful to her. But today, let's start from the viewpoint of why do we need training on breastfeeding for professionals? Sadly, because most of us didn't have any training at an undergraduate level. We've picked up things as we've gone along. We've maybe learnt things from mentors as we've gone through our working careers. Often we've picked up a lot more information as we've become parents. But how much of it is evidence-based? And is that important when we're talking to mothers and families of a newborn baby? So why listen to this webinar? The aim of this presentation is to make sure that all of us are not only supporting and promoting breastfeeding, but that we're using an evidence-based approach. And I'm hoping that this will provide all of you with an opportunity to record a CPD entry so that it has value for you as well as all the families that you will meet in the future. None of us know everything, but we all have lots of opportunity to increase our knowledge, to support the families that we encounter with whatever situation that they're in. My pre-reg tutor, when I qualified as a pharmacist, said it's impossible to know everything, but what's important is you know where to look and who to go to. That is the person who has that expertise to answer the question. What do we need to know to support a breastfeeding family? So in this presentation, I'm going to look at why exclusive breastfeeding is important for the future health of mother and child and for the health economy, be that all that it may be 20 years down the line. I'm going to look very briefly at the management of some of the common conditions that you may need to meet as a professional, and briefly touch on the issues pertaining to prescribing for breastfeeding mothers, and send you to some links for some further information, because otherwise this presentation could go on for the next 3 hours. I'm going to look at where to go for expert information and understand when we need to appropriately refer a mother to somebody else. But I'd also like us all to think how our own attitudes to breastfeeding may affect our consultation with a family. So why should we promote breastfeeding? Human milk is very special. It alters on a day-to-day basis. It alters on an hour-to-hour basis within the day. It is a living fluid that is special for that baby at that moment in time. And it also changes according to where in the world we live. So a baby born in the Sahara Desert, the mother's milk would have more watery content in it to quench the baby's thirst, whereas a mother whose baby is born in Iceland, let's say, where it's very cold, would have a lot more fat in it. We can never hope to replicate all of these things with a standard infant formula, and it's providing protection for the baby and for the mother as well. Back in 2016, there were a set of papers in the Lancet that looked at a lot of detail about breastfeeding. And one of the graphs that was presented was the prevalence of breastfeeding at 12 months across the world. And the conclusion was that UK was the worst across the world at 12 months. I think sadly the data was not as accurate as it could be because we don't collect the data at 12 months. I hear many questions from mothers who are feeding 2, 3, 4-year-olds, even older. So we know that actually a significant number of women carry on breastfeeding for more than 12 months, as I admit I did myself. Breastfeeding could be seen as the very first immunisation that we give to a baby. It doesn't cost any money. All it costs is skilled care and the willingness of a mother to learn. Breastfeeding doesn't always come as naturally as maybe we think that it does. It is a learning experience, as everything else in life is. Just like learning to ride a bike. Some people can get on and sail away. Others, it takes a little while to gain their confidence. And the Director General of UNICEF said it's a dream product that should be available to everybody, every new baby born on Earth. And sadly, we don't use it as much as we could. In this paper by Renthrough in 2008, she said that women and infants need their professionals to advocate breastfeeding, to learn the basic skills, and to ensure that breastfeeding is protected, as well as supporting colleagues. And that's actually a huge, big task in any professional's life where we have very, very limited time. In a GP consultation, you've got at most 10 minutes to welcome a mother in, to listen to her story, to prescribe, to record it on the computer. We don't have a lot of time to go into details. But it is a major health promotion issue, the same as cigarette smoking cessation, obesity, and it deserves as much time or referral to an appropriate person who does have the time. So what does breastfeeding do to help protect babies? It protects against ear infections, gastric infections, future obesity, eczema, the risks of sudden infant deaths. There are so many different things that it helps to protect against, and that protection goes on into toddlerhood. There has been some research that shows that breast milk continues to have just as much goodness when the baby is 2, 3 and 4 as it does when it's 2, 3 and 4 months old. So the mothers who I hear being told breastfeeding has no goodness left in it at 6 months, at 12 months, at 2 years, you're only doing it for your own benefit, actually are not working from an evidence base. It continues to have just as much benefit and to pass on immunity from any infection that the mother may pick up as well. For instance, I know in the last 2 years many women have continued to breastfeed for longer in order to protect their children from COVID, and some of them have also gone on to express milk to give it to their older children. There was no evidence to do that, but their own gut instinct says milk from me contains either the antibodies from the vaccine or that I have produced because I've had an infection. It also protects mothers against ovarian and breast cancer and an increased likelihood of returning to their pre-pregnancy weight because it's using up calories. For many women, one of the major benefits is, for most people, delaying the resumption of the menstrual cycle and consequential loss of iron stores. But it also very recently has been shown to reduce the lifetime risk of cardiovascular disease. This is a 2022 paper. So it has huge benefits to both of them. When a mother encounters an infection, she provides antibodies very, very rapidly. And so if a baby is not breastfed, it misses out on all the immunological components of breast milk. And if it's formula fed, there is also an increased risk of milk contamination during preparation and storage. Sadly, many women have been shown not to make up formula correctly. We know now that they shouldn't make up a day's worth in advance, as my generation were told to do. It should be made one bottle at a time. But if we put those two things together, is it surprising that more babies who are bottle fed are admitted to hospital with gastroenteritis? And an economic analysis in 2012 showed that we could save 1.34 million per annum if we just increased the current level of exclusive breastfeeding from 7 to 21% at 4 months. And this goes on the longer the babies are breastfed. And these are massive numbers. We could protect so many more people from other conditions if we had this money freed up. So what is it that is in the breast milk to protect the baby from gastroenteritis? It mops up the free iron in the gut with something called lactoferrin, and bacteria thrive on free iron in the gut. It stops bacterial growth, and oligosaccharides inhibit the attachment of pathogens onto the gut wall, and immunoglobulin A protects the gut. And what is most wondrous to me is that once it's coated all the gut, any extra goes on to line the wall of the bladder, so that the babies have less chance of getting urinary tract infections. A formula-fed baby doesn't have white cells and lysozyme, which are going to destroy the bacteria. All of these different things are never going to be replicated, however hard we try, but they're made in every drop of milk, which is why every drop matters. So how do hormones control breastfeeding? Prolactin is responsible for the ongoing synthesis of breast milk. So if you think of calling a waiter to order your next meal, prolactin is kind of like the waiter that provides the food for the next level of food, next level of the meal. But prolactin levels can be influenced by medication. So things like domperidone, metoclopramide increase prolactin levels, and we might use them in some limited circumstances to increase prolactin levels and produce more milk. Whilst aripiprazole is known to reduce it, and I've encountered a number of women now who, even on quite low doses of aripiprazole, have lost their milk overnight. And the receptor cells are primed very early after birth to optimize the milk supply. So the more the mother feeds in the first few days, the more likely she is to have a good milk supply. The other hormone involved in milk production is oxytocin, which is responsible for the ejection of the milk from the breast, and it squeezes the cells to expel it. Every mother who has breastfed will know that actually if the baby comes off when it's got the milk flowing, the milk actually spurts quite a significant distance. But levels of oxytocin can be temporarily reduced by fear, pain, stress and anxiety. But the thing that helps it return to normal is skin to skin. That feeling of relaxation and being in tune with the baby's body. And skin to skin is valuable at any time. The last part of the jigsaw is feedback inhibitor of lactation, which provides a negative feedback. So each time the baby feeds, if there is milk left in the breast, feedback inhibitor of lactation sends back the message that the body is making too much milk, so the supply downregulates. So if the baby isn't correctly attached and the breast isn't emptied, then the supply goes down. If the mother misses a few feeds because somebody else is giving the baby a bottle temporarily, the baby's supply of milk will go down. So it's important that we do have the breast as empty as possible, as frequently as possible, to have a full supply. Many women have in the past experienced engorgement. These is temporarily swollen, hot and sore breasts the first few days after delivery, round about the time when the milk comes in. Also at the time when hormone levels are shifting very rapidly and mothers tend to be quite tearful. But it's not an inevitable part of breastfeeding. If the baby is feeding frequently with good attachment, engorgement won't happen. But if it does happen, there is actually evidence for a story that you may all have heard about using cold cabbage leaves, particularly Savoy cabbage leaves, on the breast, straight from the fridge. There is an enzyme that is released which does relieve the engorgement. But otherwise, applying warmth before a feed and cold after a feed will reduce the discomfort, along with paracetamol and ibuprofen if necessary. But the main thing is having those breasts as empty as possible, which will also stop feedback inhibitor of lactation, stopping the milk supply as well. So many people report that their experience of breastfeeding in the first few days is of pain, and 32% in the last infant feeding survey, which was done in 2010, had experienced pain and nipple damage in the first 2 weeks, and 70% of women had had it at some time during their lactation. If sore nipples were intended to be part of the breastfeeding experience throughout evolution, I'm not sure breastfeeding would ever have survived. Because to feed when every time you feed is agony is hard. And women say that it's hard and it's demoralising, and worst of all, as if they're anticipating the pain, they will pull back from the baby, so making the latch worse. If a mother is experiencing sore nipples, what she needs is expert help to help her to latch the baby on properly. There are massive sales of nipple creams which actually don't prevent or even really cure breast pain. They're just making a lot of money for the manufacturers. Nipples can become very dry, but actually expressing a small amount of milk after feeds should help with this. But if there is severe pain, then the person needs to go and see an expert in breastfeeding technique, a peer supporter, the lactation consultants at the hospital. Some pay privately to see lactation consultants. Each of you should be aware of who the local groups and where the drop-ins are in your own area. The infant feeding survey also showed that 3/4 of mothers had given their baby milk other than breast milk within the first 6 weeks of their life. And so many times we hear about dads want to feed, grandma wants to feed, I just needed a break. But every time we give the baby formula milk, we're breaking down the integrity of the protection of the gut. And also, even if we're expressing at the same time, which to my head seems a little logical, somebody else can feed the baby from a bottle while you express the milk to go in the bottle. In that time, the feedback inhibitor of lactation can take effect and lower the supply. And many people end up stopping breastfeeding sooner than they planned and having massive feelings of grief and loss. And there's a wonderful book by a colleague, Amy Brown, which discusses this. Most people who give up have done so before they planned to do. So this deep latch is the most important thing. If the baby is sucking on the nipple, it causes pain and it restricts the blood flow, as you can see in the left-hand image. In the right-hand image, the baby is coming from underneath the breast, having a wide open gape, and produces pain-free breastfeeding and more milk supply. One analogy that I've often used with students is to say, if you try sucking your thumb with the pad of your thumb against your tongue, you will feel the pressure of your teeth on the base of your thumb, and it's quite far forward in the front of your mouth. And that's the analogy of the left-hand picture. If you turn your thumb over and suck it as you would do for comfort, and pharmacy students that I've done this have stood there and been very embarrassed, but I hope it's just something that they remember. Your thumb goes right over to the back of your tongue. There is no pressure at the base of your thumb, and it feels comfortable. And that's replicating the feeling of effective breastfeeding. So if you meet somebody who has sore nipples, refer them for expert help as soon as possible. If there is a crack, what you need to do is use moist wound healing to prevent scab formation, because otherwise every time the scab is removed you get a deeper and deeper wound. You don't want to use enough cream that the nipple becomes soggy, because otherwise that stops the wound healing. So as effective as any of the expensive creams, Vaseline, just a smear into the base of the wound, is as effective as all the commercially available products. If the crack looks infected and it's yellow and sloppy, then an antibacterial cream can be used again into the wound. Doesn't need to be washed off after feeds, because you're applying such a small amount. You are not applying a great big dollop. You're using kind of the amount that you would apply as a lip salve. So these are the indicators of good attachment. The baby's mouth is wide open and it's come from underneath the breast over the top of the breast to produce an asymmetrical lap, so that the chin is touching the breast. And most of all, that the mother is not experiencing pain. If I had £1 for every mother who had told me, so many people have watched my latch, but they say it's perfect, but it hurts, I would be a very rich woman. You can usually audibly hear the baby swallowing milk, and you will often see the tips of their ears waggling. But most of all, their arms and their hands, as well as their feet, become relaxed, and the woman relaxes. You can see almost like she's let out a deep breath of sigh. We're looking for regularly soaked heavy nappies. It's really difficult with the current nappies to work out how wet they are, because they're so much more absorbent than the terry towels used to be. So it's worth putting 100 ml of water into a nappy and seeing what that feels like. But importantly, there should be no change in the shape of the nipple after feed, and the woman's breast should become softened. I carried out a small piece of work when I was helping to write the BMJ paper about sore nipples, and I asked mothers, what do you want professionals to know about nipple pain? And the overwhelming response that I got back was understanding that, saying, well, it doesn't matter if you stop feeding, you've done your best, just give formula. So many people give formula, it's okay. isn't what they want to hear. They want somebody to actively help to make it right. And that it's okay if you as a professional say you don't know how to answer, but you know somebody who does. And that you don't need to always medicalise everything. It doesn't have to be a bacterial or a fungal infection. It is 99% of the time a latch that isn't quite right. But one of the things that they also mentioned is that it made them feel tearful, frustrated, angry, and yes, depressed. But that didn't mean that they needed an antidepressant. They needed somebody to help them fix the problem. And that their partners also felt disempowered. And often they would say things like, let me give the baby a bottle so that you can have a bit of a rest. That isn't helping. That's providing a very temporary solution. They need to know is where to go to for help. In extreme conditions where the breast isn't drained properly, we can get mastitis. Most mastitis is an inflammation of the breast and not an infection. And a large proportion will resolve with frequent effective feeding. And the worst possible thing that a mum can do at this time is to stop breastfeeding. It could be due to pressure on an area of the breast. It could be an ill-fitting bra. It could be a button on dad's pyjamas that mum's laid on in her sleep. But it's usually a build-up of milk in an area where the milk leaks back out into the breast and the breast treats it as a foreign object and produces the heat and the inflammation to deal with that. Antibiotics may be necessary if improved drainage hasn't reduced the symptoms, and there may be situations where the mum is clinically very unwell and just your gut feeling is that she needs antibiotics immediately. And we must never forget that sepsis can be a result of untreated mastitis. So the WHO antibiotics recommended for mastitis are Fluclox or amoxicillin, or if the mother is allergic to penicillin, erythromycin or cefalexin. Usually 7 to 10 days is the duration of the course. The mother does not need to give the baby probiotics to reduce the side effects of the antibiotic, because the baby will become temporarily lactose intolerant and have a loose runny poo. Her breast milk contains everything to restore the gut balance better than any purchased and probiotic. Tongue tie is a very specialist area, I feel. You may be able to see when you look at the baby's tongue that there's a heart-shaped tip to the nipple. There's actually a very obvious curve, and you can see the frenulum tethering it to the base of the mouth. If that happens, the baby can't push the tongue forward in order to get a good latch, and you will have an unsatisfied baby who can't milk the breast properly and significant levels of pain. Most areas have local experts in dealing with this, but some families choose to see private practitioners. And literally the frenulum is cut with a pair of scissors in a couple of seconds and the baby put on the breast and helped to feed effectively. It's often runs in families, and you will be able to hear from the speech that perhaps one of the parents has a tongue tie, or they say my mother wasn't able to feed me because it was too painful. Breast milk insufficiency is cited by very, very many people as a reason for stopping feeding. Now, we've talked already about prolactin being made at every feed to put in the order for the next feed. So the more frequently a mother feeds, the more prolactin she produces, the more milk she produces. Milk left in the breast stimulates feedback inhibitor of lactation and stops milk supply. All mothers should be able to notice the change from the browny meconium colour on day 1 down to the mustardy yellow seedy colour by day 4 or 5. If you are seeing babies with infrequent stools, it doesn't mean that they are necessarily constipated. Often it means that they are not effectively breastfeeding. There are, of course, some medical conditions, but this is the most frequently seen. So being aware of the number of times that a baby needs to pee and to poo is one of the things that other members of the family can be tasked with monitoring whilst mum gets on with feeding, in addition to making her cups of tea and providing her with food and nutritious snacks. So if you see a mum with a low milk supply, get her some help with the breastfeeding and prompt her to feed more frequently. But if you think that baby is clinically dehydrated, they may need to be admitted. It's always worth questioning whether her mum has started any new medication. For some people, even the progesterone-only pill will drop their supply, and we don't seem to know why. It doesn't happen that commonly, but it does happen to some people, particularly those who are initiated with it before 6 weeks. Have they taken any sedating kind of drug or taken a decongestant for a cold that they have at the time, or something like aripiprazole? In very rare situations, despite all of the help that a mother has had, a breastfeeding expert may ask you to consider providing domperidone to increase the prolactin and increase the milk supply. This is an unlicensed use of the drug, but has got quite a lot of research for it, particularly in preterm babies. And there is a signpost to somewhere with a lot more information that I can go through today. Back in about 1998, 1999, a colleague and I wrote the first leaflet on thrush and lactation. And we had both seen maybe 2 or 3 people a year describing excruciatingly painful nipples after feeds in women who'd been feeding for several months. And neither of us had ever been able to understand what was going on. So we did some research and found data about Candida on the breast. Sadly, it's become something that is probably very badly overdiagnosed. There certainly was a time when every case of sore nipples was treated as thrush. Candida, in my opinion, is pain in both breasts after a period of prolonged pain-free breastfeeding. That doesn't mean they had 2 pain-free breastfeeds and now it's become painful. It's over a period of weeks. And the pain is after every feed and is in both breasts. And it's usually also painful to express. And the nipples become ultra sensitive to touch. So the mum may say that when she's in the shower it hurts. It's actually very rare in the first 6 weeks, in my experience. And I have suggested, with the support of a colleague who is a microbiologist, that swabs are taken to make sure that there isn't a bacterial or candidal infection, because bacterial infection on the breast produces very similar symptoms. Overdiagnosis has sadly meant that we've had medicalisation of something that's normal breastfeeding as normal, and it's also resulted in delayed support to get pain-free breastfeeding. I recorded a YouTube video. I'm aware that having recorded this way, some of the links have disappeared, so I will provide those in a separate link for you. So again, refer to mum for expert help as soon as possible. If you do need to treat, miconazole cream applied sparingly to the nipples after feeds has the best evidence worldwide. Clotrimazole applied to the nipples seems to be ineffective and has been reported to be associated with allergy. So you've got incredibly itchy nipples as well as sore nipples to feed with, not an ideal situation. Clotrimazole should be reserved for use on the baby's buttocks if necessary. Although miconazole oral gel is outside of license in a baby under 4 months, the risk is in the method of application rather than drug. And the change in license application came from the fact that in the Netherlands, a mother was told by a pharmacist to apply it to her nipples and then to feed the baby. And the baby was still very young and had been born preterm. And the baby choked as the nipple went into its mouth with this big glump of miconazole gel. The mum scooped the gel out, the baby recovered and was absolutely fine. Nystatin is less effective and seems to be developing even more resistance. So if you look in the small box there, nystatin, even by day 12, is only just above 54% effective. Treating both the mum's nipples as well as the baby's mouth is necessary because they pass it from one to the other all of the time. Sometimes the pain continues and it's a deep breast pain, and the evidence worldwide is that we need to use fluconazole, and dosages can vary. But in neonates less than 6 weeks old, fluconazole has a very prolonged half-life, and the accumulation can cause stomach pains and vomiting. But if the symptoms aren't improving at all within 10 days, then I think we need to go back to the beginning and look again at the diagnosis. It's often said that breastfeeding causes depression, that the pressure of being told to breastfeed, that breastfeeding is the best for the baby, is what causes women to struggle and precipitate depression. But many more mothers have told me that actually it was the pressure to stop that made them feel sad and depressed. They said they wanted to be listened to and to have breastfeeding support. The way we address parents may depend on our own experiences of feeding our own children, and perhaps we need an opportunity to debrief those experiences, or breastfeeding peer supporters have to debrief as part of their training. So if we have formula fed our own babies and we perceive them to be perfectly fit, healthy and well, and what's all the fuss about, then possibly we will think perhaps twice about advocating breastfeeding on a long-term basis. But repeat again, it's about health promotion. We can be overweight and still say losing weight is good for you. I ran an obesity clinic for many years, and it made me stop and think about my weight and how I was eating. I'm sure many of us have told people to stop smoking whilst continuing to have the odd cigarette outside of the practice. The research study by Borra in 2017 actually said that the lowest risk of postpartum depression was actually seen in women who planned to breastfeed and were enabled to do so for as long as they chose. But the highest risk was amongst those who planned to breastfeed but had not gone on and been facilitated to feed for as long as they wanted, or maybe even at all. So they set out with a goal, they perceived that they hadn't reached that goal, and they labelled themselves as failures. Nobody else labelled themselves as failures. This was their own perception because they hadn't reached their own goals. It's very wrong to say that breastfeeding advocates will make a woman feel guilty if she hasn't breastfed. Most of us will go 10 miles further to make sure that we support women to feed for as long as they can, and we'll just listen and say, you did really well. But sometimes somebody telling you you did okay isn't enough. It's what's going on in your own head. Women who haven't reached that duration may be feeling that for others breastfeeding was straightforward. And if they did have difficulties, it causes a lot of grief and sadness. And both Amy Brown and I have heard of women talking to us about breastfeeding many years after they delivered and saying, I wanted to, but I couldn't. And that's why good breastfeeding support is so important. It actually seems that the more frequently you feed, the less likely you are to feel depressed. And part of that is the magical hormone oxytocin, which is about bonding and relaxation. And if we tell a mother to stop breastfeeding, that oxytocin level is lost. And this came out again in the survey that I asked women what they wanted healthcare professionals to know about needs if they had mental health problems already. And it clearly came out that they didn't want to stop breastfeeding in the largest part. They wanted to be listened to, they wanted to get evidence-based information. And this one person who, as the mum described it, knew her stuff, was seen as being a real help in a challenging time. What vitamins do women need when they're breastfeeding? The NHS recommends that all breastfeeding mothers should consider taking a vitamin D supplement. Many of us are now vitamin D deficient because we use sunscreens, we don't go out in the sun as much, and we don't always eat the right foods. And that the baby should be given a supplement as well. For mothers who are deficient, we may give much higher doses, and there is a fact sheet there about the doses that can be given. There's actually, a mother can take 6,400 micrograms a day before she secretes the equivalent of the baby's supplement in her breast milk. So we can actually give very large doses without detriment. My passion is talking about prescribing for breastfeeding women. And I'm very sad that most drugs prescribed during lactation are outside of the product licence, and that all the patient information leaflets say things like, do not take if you're breastfeeding. And in the past, the BNF has said things like amount in breast milk too small to be harmful, but the manufacturers advise avoid. And this has really been about the licensing of a drug, and when a drug is produced, not for the manufacturer not having to take responsibility, but not altering this later on when there are some studies available, and not considering the pharmacokinetics of the drug. I got involved in quite a big battle in December 20 to January 21, when it was said that the COVID vaccine could only be given to a breastfeeding mother once she'd ceased breastfeeding, and that many professionals felt that they had to stop because they needed the vaccine to protect themselves and their families. But knowing that the vaccine wouldn't be bioavailable and wouldn't pass to the baby, and I and many other experts were saying this, and it took most of the holidays and before the MHRA did come out and say that they were licensing it during breastfeeding. But by that time, a lot of data had been published, a lot of leaflets, and it took time for those to be removed, and it caused a lot of confusion and possibly some vaccine hesitancy. There is a recommendation in the 2008 version of NICE maternal child health nutrition recommendations. They recommend looking at the UK Dialis and the LactMed websites. I've also written quite a few sheets for the Breastfeeding Network, which are not referenced in the NICE recommendation, and I've continued to write more on my own website, Breastfeeding and Medication. This is just because I've done the research to save you the time, because I appreciate how little time you have available. There are a few drugs which are completely contraindicated in breastfeeding, and obviously the first amongst those is chemotherapy. A lot of the others, there are drugs that we don't largely use anymore, but I do want to highlight iodine dressings. These can be absorbed, enough iodine can be absorbed from the dressing to increase the level in breast milk, and it appears to concentrate and sufficient pass to affect the baby's thyroid. Illicit drugs clearly should not be used by breastfeeding mothers, but I and my colleagues who now work on the BFN Drugs and Breast Milk Helpline see many questions about the use of cocaine, and it appears that this has become part of society. Methotrexate can't be used during breastfeeding with the current information that we have, except for use to help with an ectopic pregnancy or when sufficient has gone from milk after 24 hours. Drugs to use with caution, I keep coming back to aripiprazole, and I have also seen women given combined oral contraceptives. I'm aware that national guidelines say that these can be prescribed for 6 weeks, but I frequently see them resulting in low milk supply, and everybody assuming this was just another mum who wasn't able to breastfeed. Decongestants, particularly pseudoephedrine, may reduce the supply. One dose has been shown to reduce supply by 24%. Similarly, diuretics, obviously going to remove fluid from the body, may reduce supply. We also try to avoid codeine. One baby in Canada died following maternal use of codeine after a caesarean section. The mother repeatedly bent back to the baby's paediatrician, said the baby's drowsy, it's not feeding effectively, not happy, it's making me feel constipated and unwell, and the mother's dose was reduced, but she still went back and said it's not right, and she was ignored and told to just see a lactation consultant. Sadly, the baby died, I think it's something like day 17, and at post-mortem it was found that the baby had far more codeine in its system than was expected, and the mother had a metabolism that concentrated the drug in her breast milk. This is relatively rare, and most people who have this metabolism will avoid codeine and opioids generally unless absolutely necessary. But because of this risk, particularly if we've got an opioid naive mother, the MHRA have recommended that codeine is not prescribed. Dihydrocodeine is preferable because it's metabolized in a different way, extensive first pass metabolism, and doesn't depend on the way the mother's body reacts. Generally, centrally acting drugs may cause baby in the drowsiness, and this may include things like chlorpheniramine, as well as sleeping tablets and things like that. We may also need to use a slightly older drug where we know the pharmacokinetic data and have some information. And one example that comes to mind is enalapril rather than ramipril, because we have data on its use directly in children, and it produces low levels. So if we need an antihypertensive, that's the ACE that we would choose. Before prescribing, let's talk to a mother about how much she needs the drug. Is this a self-limiting condition where she could actually cope without having anything? And what's the risk to the baby of being exposed to the drug? Are there any that are more compatible? So, example, enalapril rather than ramipril. And we need to protect breastfeeding unless the mother tells you that she wants to stop. So rather than say, I want to prescribe this drug, can the mother continue to breastfeed? Maybe we should be asking, this mother is breastfeeding, what drug can I supply to her to enable her to be treated effectively and continue to breastfeed? And let the mother know what potential side effects there might be. So, for example, with antibiotics, that the baby will have loose runny nappies, and that is self-limiting. Milk supply doesn't turn off like a tap, and interrupting feeds may lead to mastitis. And contrary to common belief, not all babies will take a bottle. So, as I say, let's turn round the importance and put breastfeeding at the centre of the issue. So advising a mother to stop breastfeeding denies the right of the baby to breastfeed and the right of the mother to continue to breastfeed. And we should be looking at full quantitative data from an expert source. The BNF is changing at the moment and is becoming an expert source. UK Dialysis and LactMed are the go-to free sources of information. Phil Anderson wrote a paper back in 2003 that actually the way we talk about medication may give subtle cues. So even a kind of a drawing in of breath before you write the prescription, or a slight hesitancy may influence the mother. And in actual fact, some mothers have been found to refuse to take the medication rather than stop breastfeeding, and particularly around depression will say, I don't want to risk exposing my baby to that. Anderson looked at all the individual reports of adverse events. Only 22% of adverse events were in babies more than 2 months, but this is the group of mothers I have taken most questions from in the last 20 years of running the Drugs in Breast Milk Helpline. In the early days, custom and practice allows us to prescribe because it's in a maternity situation and we're used to using these drugs. If you're in a GP in your own and you don't know, it's possibly easier, safer. I don't quite know the word that I want to use to say it maybe is better. I don't know what's going to happen. But actually what we could do is check the information, and that's why I wrote the fact sheets, to save you time, or to say that you will issue a prescription but contact the mother later in the day when you've asked somebody else, that you can phone UK Dialysis, you can search LactMed. And maybe we're thinking that babies over the age of 2 don't need to be breastfed. They still do benefit, as do the mothers. So, my conclusion, I feel it's the role of all of us, because breastfeeding is a health promotion issue. And this presentation is not about pushing mothers to breastfeed if they don't want to. Everybody has the right to raise their child in exactly the way they want to. But I want to provide evidence-based information for the mothers who have chosen to breastfeed and who maybe have had a really tough start and struggle to breastfeed, and you're seeing there were a couple of months along the line saying it doesn't matter if you breastfeed. It matters to them, and they need to be listened to. We can treat most conditions during lactation, and I hope that you can use what you've learnt here to record your own CPD. As healthcare professionals, we all need updates on breastfeeding and about the safety of breast milk, but we need to be sensitive to the needs of all mothers around infant feeding. If I can be of any help, I'm always very pleased to have an email or a message on Facebook. I'm here to support you in something that I'm quite passionate about and have given my life to. So thank you for listening. I hope it's been of benefit. Bye bye.